So today we're going to be going over the 2020 in-service training on bloodborne pathogens. This is a 2-hour block of instruction. We should be able to get this done anywhere between about 35 and 45 minutes. I am not sure if Lieutenant Manning has a test on this or not. If there is a test, what you'll find is that all the answers will be in the class outline, which should be on Power DMS along with this video. First thing we're going to go over is the training objectives. The primary training objective, the first one, review the purpose of the Bloodborne Pathogen Standard in OSHA 29 CFR 1910-1030. Characterize the general symptoms and epidemiology of bloodborne diseases. Distinguish the modes of transmission for bloodborne pathogens. Identify tasks and other activities which may involve exposure to blood or other potentially infectious materials. Demonstrate methods which prevent or reduce exposure to blood or other potentially infectious materials. Illustrate the appropriate selection, storage, use, and disposal of personal protective equipment. And finally, outline the components of their employees' bloodborne exposure control plan to include appropriate actions and persons to contact in an emergency involving blood or other potentially infectious materials. The procedure to follow if an exposure incident occurs, and information on post-exposure evaluation and follow-up. One of the things that is not in these objectives is anything about COVID or coronavirus. I'm not going to add anything to the lesson plan on this, but as we go through the lesson plan, as we get to parts that are going to apply to COVID exposures and what to do to avoid a COVID exposure, we'll talk about it as it comes up during the course of the lesson plan. Okay, first thing, Bloodborne Pathogen Standard 29 CFR 1910-1030. This is the federal regulation that defines what an employer has to do to protect their employees from any type of bloodborne exposure. Before we go too deep into the Code of Federal Regulations, we've got to go through the definitions that are in the Bloodborne Pathogen Standard. The first one is a bloodborne pathogen itself. And a bloodborne pathogen, according to OSHA, is any virus or infectious agents that are carried in the blood. The other abbreviation they use is an OPIM, and OPIM stands for any other potentially infectious materials. And what they're talking about in this one is anything other than blood that is a body fluid that could potentially carry any kind of infectious material. One of the things we'll talk about a lot with COVID is respiratory secretions. Respiratory secretions, although it's not a bloodborne pathogen, but respiratory secretions carry viruses, and that's what we're concerned about primarily with COVID infections. And then the other thing that we're going to talk about is an exposure. An exposure is any incident where the employee has non-intact skin, eye, mouth, or mucous membrane or under the skin contact with blood or other potentially infectious materials. Again, this gets a little bit different when we start talking about COVID infections. One of the things we've discussed in prior classes is that intact skin is a barrier to infection. Typically what I ask people is, if you get a splash of blood onto intact skin, is that considered to be an exposure? And the answer, of course, is that it's not. Intact skin is a barrier to infection. But one of the things that we're beginning to learn now with COVID is that if you're in the presence of a person who has got a COVID infection, neither one of you have masks on, and you're with that person for 15 minutes or longer at a distance of 6 feet or less, that's going to define an exposure to the COVID virus. So those are a couple of magic numbers that you need to remember just for your own benefit. If you're around a person and you're with them for more than 15 minutes and you're closer than 6 feet, if they have got coronavirus, if they have a COVID infection, at this point you've been exposed to it. So you need to assume that at that point you've had an exposure, and that of course would start the whole quarantine issue. Exposure control. When we talk about exposure control, there are a couple of different things we talk about. The first one is the administrative controls. Administrative controls are things like vaccinations, training programs, mandatory continuing education, anything where you're going to get an email from the administration telling you that you have to do something is an administrative control. Second thing that we would talk about are engineering controls. These are physical barriers to exposure. You see these a lot in healthcare facilities, you see them a lot in medical equipment. IV tubing is designed so that you only use one needle to start an IV and then you don't use any other needles to draw out meds. One of the examples I've used in the past has been airports. Airports are a huge reservoir for infection, and if you go to a large international airport, one of the things that you'll notice is that the bathrooms are always designed so that there are no doors to the bathroom. You simply walk through sort of a little zigzag maze thing, and that's an engineering control in order to cut down on infection, just because there's a door that you don't have to touch to open it. One of the things that we're seeing a lot now with the concern over COVID infections is a lot of plexiglass screens in front of cashiers in grocery stores and convenience stores and places like that. These are all engineering controls just to cut down on the amount of respiratory secretions that people are getting exposed to. And then the third thing that we talk about are work practice controls. And these are the actual procedures that we follow every day to reduce exposure. Prior to this whole pandemic mess, what we would have done for a work practice control would be wear gloves if you're around any body fluids, keep your distance from any type of environment where you might have blood splashing, things of that nature. With the pandemic, our work practice controls are now things like wearing a mask in public, reducing the amount of time that you're in other people's space, reducing the amount of time that you're in crowded environments. And these are our work practice controls to control the spread of COVID. We're going to talk about symptoms and epidemiology, and when we do, we're going to talk about the 4 biggest diseases that we have to worry about. These are hepatitis B, hepatitis C, human immunodeficiency virus, and then something called methicillin-resistant Staphylococcus aureus, or MRSA as most people call it. We'll also at the end of this also talk real briefly about COVID infections, just so you've got a good handle on what that is. Hepatitis B. Hepatitis B is, first of all, what is hepatitis? In the world of medicine, anytime you see itis on the end of the word, it means a swelling or an inflammation. HEPA, H-E-P-A, in this context, of course, refers to the liver. So when you see hepatitis B, you can look at the word and you know that it's talking about an inflammation or a swelling of the liver. Well, these are your signs and symptoms of hepatitis B. Jaundice, jaundice, fatigue, fever, loss of appetite, nausea, vomiting, abdominal and joint pain, and gray-colored stools. A lot of these are really nonspecific. Fatigue, fever, loss of appetite, that can be any type of disease. That can be the flu, it can be a bad cold, it can be just about anything. Jaundice, however, is kind of specific. Jaundice refers to a yellowing of the skin. And you get that as the liver begins to fail and it's not removing toxins from the blood. As the toxins build up in the blood, your skin has a tendency to take on a sort of yellow hue to it. Everybody's skin is a little bit different. Some people are a little bit darker, some people are a little bit lighter. It can be tough to look at somebody's skin and know if they've got jaundice. Typically, the best way to look at a person and tell whether or not they have jaundice is to look at the whites of their eyes. No matter what ethnicity a person is, if they have jaundice and it's showing up in their eyes, you're going to be able to see it much better there than anywhere else. One thing to bear in mind is that by the time a person with hepatitis B is displaying jaundice, they're deep into liver failure at that point, and they have had hepatitis B for a considerable length of time. And I'm going to go back for 1 second, just finish up one thing on hepatitis B. Hepatitis B shouldn't be a great concern for anybody who's taken this class. One of the things about getting hired at the sheriff's office is that you are required to take a hepatitis B vaccination. The hepatitis B vaccine is a series of 3 shots that you take over the course of 6 months, and it gives you basically 99.999% immunity to hepatitis B. It is a bloodborne virus, but if you've had all 3 of the vaccines, there's basically no chance that you're going to get it. If you've only had 2 of the shots, only 2 of the vaccines, you've got 66% immunity. If you've had only 1 of the injections, then you've got 33% immunity. So as you're sitting here thinking about this, we have had a problem in the past with people who would get the first in the series of injections, they'd never go back for the second 2. If you're thinking about this and you have not had the second and third vaccines, you need to get in touch with your supervisor, make arrangements to get the last 2 of those injections. It's important to get those just for protection for yourself and also your family. Hepatitis C. Hepatitis C is very similar to hepatitis B. People can be infected and have no symptoms, and they can be infected and be asymptomatic for absolutely years. And there is no vaccine for hepatitis C. A couple of people are at higher risk groups for this. Baby boomers seem to be at higher risk for it. People with multiple tattoos seem to be at higher risk for it. Veterans seem to be at higher risk for it. And of course, people who have IV drug addictions seem to be at higher risk for that. But it basically presents very much the same as hepatitis B. Treatment for this is really expensive. There is a treatment that's available for hepatitis C. It's I think it's a 60 or 90-day course of treatment, and it's fairly successful. The problem with the hepatitis C treatment is that it tends to be really expensive. Last time I looked at the numbers for this was probably about a year or so ago, and my recollection is that for a 60-day course of treatment for hepatitis C, it ran about $60,000. So, and we'll talk about that a little bit more when we talk about the exposure control plan. But there is a treatment for hepatitis C. There is no vaccine. Human immunodeficiency virus, also known as HIV. HIV is a virus that causes AIDS. This is probably the first bloodborne pathogen that we really worried about. And these are some of the symptoms of AIDS itself. HIV infections are frequently asymptomatic. There is absolutely no sign or symptom to go with a positive HIV test. But as HIV progresses into AIDS or AIDS-related syndrome, these are some of the things that you would have. You'd have night sweats, headache, fever, fatigue, swollen lymph glands, muscle pain, joint pain. Chronic GI issues, chronic diarrhea is pretty common with it, as is what are called opportunistic infections. In other words, a person with HIV and HIV infection has got very little immunity to the common colds and things that are sort of going around. And so something that would give a non-infected person maybe just a cold and put them out for a couple of days, to a person with HIV, they may end up with a pneumonia and be in the hospital for several weeks. There is no vaccine for hepatitis or for HIV, but there are some very successful treatments for it. It used to be that HIV was, we called it a 5-year death sentence, and very few people lived past 5 years from the time they were diagnosed with HIV. Many people live out the course of a normal life as long as they maintain their treatment with antivirals for HIV. The last thing we're going to talk about is something called methicillin-resistant Staphylococcus aureus. And this is essentially just, it's a staph infection is all it is. MRSA is kind of a normally occurring bug that's all around us. If I were to go around and start culturing people's skin, probably everybody in this room at some point or another has Staphylococcus aureus somewhere on their skin. Some people, for whatever reason, end up with these skin infections that can become actually pretty severe from MRSA infections. What you start with is something that looks like a pimple or maybe a spider bite or a bug bite, and then the skin lesion can develop into a deep, almost like a boil infection, localized infection that can go down into the muscle, bone, and tendons underneath. They're red, they're painful, they're very warm to the touch. There's lots of drainage coming from them. They can be difficult to treat. Sometimes they're treated with IV antibiotics. The IV antibiotics come with their own issues because the antibiotics have a lot of side effects. And sometimes they're treated basically surgically, almost like a burn, and the affected tissue is sort of excised surgically, and then they debride the area. Either way, they can be difficult to get rid of. We have people coming into the courthouse fairly regularly with MRSA infections, and they're bandaged up. And typically there's not an awful lot you can do about it in terms of infection control other than keeping the workplace as clean as you can. Spray everything down, wipe it down with some sort of antibacterial. Bleaching water is always good to do that. One of the places where we do worry about there being an outbreak of MRSA, we don't worry about it now, of course, because the gyms are closed, but gyms are a wonderful place for people to get MRSA infections. It's not at all uncommon for gyms to have outbreaks of MRSA infections from people using the equipment, not wiping it down when they're finished, not wiping it down before they get on there. Once the gyms do open back up and we can get down into the basement and the weight room, just be sure and wipe down the equipment before and after you use it, and that'll cut down on the MRSA transmission quite a bit. We will talk about COVID real briefly. COVID, of course, is a viral illness. It is spread by the coronavirus, and a couple of the things that are interesting about COVID infections. First of all, the infection has a very long latent period. It can be as long as 12 days. What that means is that once you get exposed to the virus, you can have the virus within your body, be contagious, but not really have any signs or symptoms for up to 12 days. So if you do get exposed to this, and you need to prepare yourself for the fact that you're going to be basically on quarantine for about 12 days until we can be sure that you didn't actually get a COVID infection during the course of your exposure. The COVID infections, in terms of the signs and symptoms, they can range all the way up to people who are in the hospital on ventilators and in the intensive care unit and not breathing on their own, to somebody who may have no symptoms at all, or maybe just mild cold type symptoms. So there's a huge range that you can see with COVID infections. One of the things that is kind of specific, kind of unique to COVID infections, is that most people who have this report a loss of a sense of smell and a sense of taste, or they report a change in the way they smell and taste things. People say that they have a metallic taste in their mouth, or they just don't taste things at all. So those are a couple of the signs and symptoms that we look for with COVID infections. Okay, modes of transmission. When we talk about modes of transmission, we basically, we've got three different ways in which it can be transmitted and two different types of exposure. Two different types of exposure are contact exposure, are direct contact and indirect contact. Direct contact is when the pathogen is passed directly from one person to another. If I cough on my hand and then shake hands with you, that's going to be a direct contact. Indirect contact is when there's any kind of a intermediary surface. If I were to cough on a table, or bleed on a table, or leave a dirty infected needle on the table, and somebody were to either touch that infected material or stick themselves with a needle, that is what you would call an indirect contact. And what defines indirect contact versus direct contact is that there's some sort of intermediary surface or material that contains the infected blood or material. There's droplet exposure. Pathogens expelled during coughing, sneezing, talking, etc., and are then transferred to an exposed person's mucous membranes. This is what we think of when we think about flu and cold and the way those types of illnesses are transmitted. This is also the way in which people believe the majority of the COVID infections are transmitted through respiratory secretions and droplets. There's one thing that's a little bit different though, and that's what's called an aerosol exposure, an airborne exposure. Anytime you exhale, there's moisture that comes out of your mouth, and that moisture will contain viruses and bloodborne pathogens and things of that nature. They're tiny little fine droplets. They can go a long way. They are suspended in the air for a period of time, and there's a growing body of evidence. You've got to remember that the COVID infections are new. They've only been around for about 9 months, and so we're finding more and more about this every day. But there's a growing body of evidence that airborne exposures are going to be a huge factor in the transmission of COVID illnesses. Droplet exposures are definitely a factor, and airborne exposures maybe and probably are. That's what the most recent evidence suggests. Here's the important thing about that, and that is that you have got to wear masks. The sheriff has mandated that people wear masks when they're on duty or in uniform. And I would really urge you that if you're in public and around other people, you should go ahead and wear a mask anytime you're around other people who aren't within your own family or your own living situation. One of the problems with COVID that is unique to COVID infections is that a lot of people get this and have absolutely no signs or symptoms, but they can spread the disease. And this is the way they spread it, through droplet exposure and airborne exposure. If you're going to be around elderly people, people who have any kind of compromised immune system, it's really, really, really important that you wear a mask. This is not to protect you, it's to protect them. If you have this virus, you don't realize it, you've got what's called a latent or a hidden infection. You can get a lot of people sick without meaning to. Old people do not do well with this. People with compromised immune systems do not do well with it. So I think that wearing a mask in order to protect people is not an awful lot to ask. One of the other things that I'll add to that is that I see a lot of people who are wearing these masks that have exhaust valves on them. That will help protect you, but it doesn't do anything to protect the people around you. If you have had an exposure and you're wearing a mask because you're afraid of getting somebody else sick, if you're wearing a mask that's got the exhaust valve on it, that doesn't do anything to keep either the droplets or the aerosols in around your face. You're just blowing them out into the air around you. One thing that I'll add on top of that is that we do at times have to go into healthcare facilities. We have to go into nursing homes, we have to go into hospitals, we have to go into the emergency rooms. If you have to go into one of these places, healthcare facilities are somewhat saturated with this virus at this point. I would urge you that if you're going to go into one of these places, wear an N95 masks. Most of these masks, a cloth mask, a surgical mask, those are designed to keep the virus in your face so that you don't spread it to somebody else. The N95 masks are designed to protect you from the virus coming into you. So if you're going into a high-risk environment, nursing homes, hospitals, any type of healthcare facility, get an N95 mask, wear it for the entire time you're in that facility. Okay, moving right along, modes of transmission. What are the risks of exposures? So you can get direct contact from exposure while you're providing first aid, being bitten by a suspect. That's also another example of a direct contact. Indirect contact, processing evidence, any kind of surface contact, or needle sticks. A lot of people are surprised that a needle stick is an indirect contact, but again, since you have that intermediary surface, the needle, that makes it an indirect contact exposure. And then, of course, you get droplet and airborne exposures just by being there with the person. So how do we minimize the risk? Well, the first thing is standard precautions. If it's wet and it's not yours, don't touch it. Wear gloves with everyone. Transmission-based precautions are what you would use for a particular high-risk environment. And then you have your work practice controls. A couple of examples of the standard precautions. Use your standard precautions in all situations where blood or other potentially infectious material are present. Again, like I said, avoid contact with blood and opiums whenever possible. If it's wet and it's not yours, don't touch it. Wear disposable gloves. And I'm going to add to that that you need to wear a mask at all times when you're in somebody else's house, or if you're going to be within 6 feet of somebody for 15 minutes or more. Use all your personal protective equipment, wash your hands often, dispose of the contaminated PPE properly, and then clean and disinfect your work areas. Transmission-based precautions are used when individuals are known to be infected. And use them in addition to standard precautions. I would say that with COVID, if you're going into a hospital, wearing an N95 mask would be a transmission-based precaution. And then, of course, we have respiratory masks under transmission-based precautions. Isolate any infected suspect or subject from any other victims or suspects. And clean area thoroughly with approved cleanser. 90% of the time we just use bleach and water, and that works great on just about everything. Work practice controls. Follow all your policies and procedures. Do not eat, drink, or smoke where contaminated surfaces may be present. I can't see people doing that, but evidently it has happened. Do not apply makeup, lip balm, or handle contact lenses in potentially contaminated areas. Again, I can't see anybody doing that, but evidently somebody has, because it's in the lesson plan. Do not store food in a refrigerator where other blood or potentially infectious materials are kept. That shouldn't be an issue for us. Let's talk about personal protective equipment for a minute. Gloves. Gloves are supposed to be nitrile. We do not use latex gloves anymore. If you find that there are any latex gloves, go ahead and throw them out. They don't really help. They do more harm than good, in fact. Wear them all the time. Wash your hands with soap and water after you remove your gloves. If you don't have soap and water, use some of the hand sanitizer, which is all over the place right now. Dispose of properly by throwing them in the trash, and do not reuse any gloves. Gowns, we don't actually use gowns very often. About the only people that I see using gowns on a regular basis are forensics when they're processing some kind of a crime scene. If we are doing some sort of a standby at the hospital, you may have to wear a gown. If you are guarding a prisoner, just follow the directions of the nurses there and they will walk you through it. You basically use the gowns to protect your clothing from any type of contamination. And then dispose of the contaminated gowns properly. And again, at the hospital, they'll usually have a biohazard bin for you to throw everything into. Masks should be worn when splattering or splashing is anticipated. It protects mucous membranes and nasal passages. Dispose of once worn can be given to a subject known to be infected to prevent airborne exposure. This has changed a lot just within the last 6 months. Masks are worn pretty much all the time now, anytime you're in public. Surgical masks are acceptable, cloth masks are acceptable. What we're looking for is just anything that will reduce the amount of respiratory droplets and aerosols that you're putting into the air. Again, if you go into a high-risk environment, switch that out and put an N95 mask on. When you put the N95 mask on, one of the things that I've noticed is that a lot of people will modify the straps on the N95 mask so they go behind their ears, or they don't go around their head, or they'll sort of bend the nose piece so it's a little bit more comfortable. What you want with the N95 mask is you want a really good seal around your face. So typically don't do any modification to the straps that go around your head. Don't bend it other than to mold it to the shape of your face. And the idea is that they're going to be a little bit uncomfortable. You want a good seal around your face to keep any aerosols away from you if you're going into a high-risk environment. Eye protection protects eyes from splashing and splattering. Regular eyewear is not sufficient. These glasses would not cut it. You need something on the side. And may be disposable. If so, dispose of properly. Otherwise, just clean them with the bleach. When it comes to COVID infections, there is also some evidence that more people than was anticipated have actually gotten COVID infections through their eyes. And the reason why is because they get the respiratory droplets or the aerosols on their hands, and then people will rub their eyes. Mucous membranes are great for absorbing viruses, and there are some people who feel that eyes are a somewhat neglected part of infection control for the COVID virus. CPR shields, use whenever you're giving rescue breaths. I keep one on my keychain. You should know the kind of CPR shields you have over at the detention center. We have primarily the ambu bags. In the courthouse, we have ambu bags on, I think, 4 of the floors. And they're readily available. Of course, we teach hands-only CPR so that if you are in a situation where you have a person who's in a cardiac arrest, you can always do hands-only CPR and just go right around that problem. Packaging and disposal of contaminated clothing or equipment. Make sure that anything you throw away is in a non-penetrable container, especially if you're throwing away needles or something like that. Take them to the one of the fire stations, one of the EMS bases, and they'll be glad to take care of it for you. The containers have to be clearly labeled, and they have to be labeled as a biohazard, and they've got old material to do it over there. This is our employees' exposure control plan, and this is of particular interest to the supervisors. But the plan's got to be reviewed annually and updated as needed. We have to offer hepatitis B vaccines. There has to be a contact person. The contact person, as it stands right now, is me. But what has to happen is that if you have an employee who is exposed to somebody else's blood, body fluid, or any kind of potentially infectious material, there are 2 people who need to go see a physician. The employee has to go see a physician, and the person to whom they've been exposed has got to go see a physician. And then we've got to make sure that those 2 physicians talk to each other and coordinate treatment. The easiest way to do this is usually to call Corvell, get permission for the employee to go to Duke, because they've got the infectious disease clinic there. And at the same time, the suspect or the person who's under arrest or the person to whom they've been exposed also needs to go to Duke. If we have them both go to Duke, then we can get the testing done a little bit quicker, and we can get the physicians to coordinate treatment a whole lot quicker that way. That can cut several days off. This is usually about a 4 or 5 day process. There's really no reason it should take much more than about maybe 4 or 5 hours, but by the time we cut through all the legal red tape for the physicians to release information to each other, and it's got to go through risk management and legal over at Duke, it typically takes about 4 days to get some of the results back. But the primary thing is just to make sure that each person goes to a physician, and if those physicians are both over at Duke, then that makes things much, much, much easier. This is what you're entitled to as an employee. You're entitled to a medical evaluation and follow-up. One of the things that I talked about when I was talking about hepatitis C was I was talking about the cost of the treatment for it. If you have a bloodborne exposure and you don't do the documentation on it, you think it's not that big of a deal, you're not going to mention it to your supervisor, you're just going to not worry about it, and then it turns out that you have hepatitis C at your next physical evaluation, Durham County is not going to be liable for the $60,000 or $70,000 that it's going to cost for your medical treatment. This is why it's so crucial that you have an exposure, or you think that you've had an exposure, that you go ahead on and do the paperwork on it. Everybody needs to get tested so we know what people's baselines are, and so that if you do get sick down the road, you will be covered by the county on it. And I cannot stress enough how crucial that is. One of the things that we're seeing a lot now with the COVID infections is that people are being exposed through either family members or friends, or they're in a situation where, for whatever reason, a mask is not used and they have an exposure. And typically what happens is that if you have an exposure to a person who has COVID or is under investigation for COVID, usually you're looking at about a 12-day quarantine on that. If you do have a febrile illness or you have a fever and it looks like you may actually have a COVID infection, then what we're looking for is you have to be 3 days without a fever, plus it has to be 10 days from the date of exposure before you're able to come back to work. So again, those are two numbers to remember. If you have an exposure and you're in quarantine, that quarantine is going to be 12 days. If you have an exposure and then you get sick, it's actually only 10 days from the time of exposure, as long as you're without a fever for at least 3 days. And that's under ideal circumstances. Of course, some people are out for much longer than that. Some people are hospitalized for weeks with this stuff. I am the point of contact for that. If I'm not available, you can certainly contact the on-call EMS supervisor, ask to talk to their infection control officer. Their infection control officer is a guy called Lee Van Fleet. Lee is very good at this stuff, and he will be able to offer you any kind of guidance you need if for some reason I'm not available. Let's go back over our training objectives to make sure we covered anything. Review the purpose of the Bloodborne Pathogen standard in 29 CFR 1910-1030. I think we went over that. General symptoms and epidemiology of bloodborne diseases. We talked about HIV, hepatitis B, hepatitis C, and MRSA. We also discussed briefly COVID infections. We talked about the modes of transmission for bloodborne pathogens. We talked about airborne exposure, aerosol exposure, respiratory droplets, direct contact and indirect contact. And then we talked about tests and other activities which may involve exposure to blood or other potentially infectious materials. We talked about the methods which prevent or reduce exposure to blood or other potentially infectious material. We talked about the selection, storage, use, and disposal of PPE. Then we went over the components of the bloodborne exposure control plan. Again, if anybody has any questions about this, if you have somebody who has an exposure or you think you may have been exposed or you're just not sure what to do, please give me a call with any questions. My phone number is 919-402-3215. I do ask that you give me a text if it's real late at night, or if it's an emergency, just go ahead and call me directly. Again, if I'm unavailable, just call the EMS supervisor that's on call. And if we don't know the answer to your question, we will probably be able to find somebody who does.